Hello, everyone. Welcome to the new July's school webinar of AFOMP. So today we are talking about something about the image application in the radiotherapy. As start, I will introduce our moderator today. So our moderator today is Dr. Hui-Yu Tsai. She's a professor at the Institute of Nuclear Engineering and Science, National Tsinghua University, and she's a certificate in medical physics. She had earned her degree from the Department of Nuclear Science and the National Tsinghua University with 20 years of experience in medical physics and radiation protection in medicine. Her research interests lie in advancing radiation safety for both patients and medical personnel in the field of diagnostic imaging and radiation therapy. She has cooperated with radiologists, oncologists, and experts in radiology and radiotherapy, serving as a principal investigator or co-investigator in various research projects funded by the government grants. Also, in addition to her academic pursuits, Dr. Tsai has made significant contributions to the scientific community. She has authored 74 articles in peer-reviewed scientific journals and has been invited to lecture and chair sessions at international or national conferences, as well as hands-on workshops in related fields. Her expertise is recognized by her long-standing service as a review for academic journals such as Radiation Protection, Dosimetry, Biomedi Research International Journal of Digital Imaging, and Scientific Reports. So currently, Dr. Tsai, the research focuses on the development of LET detectors, national collected dose in medicine, and occupational dose. These are areas representing her ongoings. So now I would like to hand my microphone to Dr. Tsai to moderate today's school webinar of AFOMP. Please, Professor Tsai.
Thank you, Dr. Jim, for the wonderful introduction. Good day, ladies and gentlemen, distinguished guests and esteemed participants. Welcome to today's highly anticipated webinar on the topic of imaging restriction and its impact implementation in radiotherapy. We are delighted to have each and every one of you join us as we delve into this critical aspect of radiation therapy and its implication of patient care. Before we proceed, I would like to extend my warm welcome to all the attendees. Your presence here today reflects your commitment to staying at the forefront of advancement in radiotherapy and your dedication to improving patient outcomes. We highly value your participation and encourage you to actively engage throughout the section. Please feel free to type your question and the query in the chat box, and our speakers will address them following their presentation. All right, without further ado, let us begin by introducing our first speaker, Dr. Adam Yu. Dr. Yu is a certified medical physics at the renowned Peter MacCallum Cancer Center, where he leads the physics team in developing a compelling business case of proton therapy. With his expertise and leadership, Dr. Yu is at the forefront of advancing this cutting-edge treatment modality. In addition to his work at the Peter MacCallum Cancer Center, Dr. Yu holds honorary research fellow positions at the University of Melbourne and RMIT University. His academic affiliations highlight his dedications to both clinical practice and academic pursuits. Recognize his exceptional contributions. Dr. Yu has received numerous awards, research grants, and fellowships throughout his career. He is currently involved in training and supervising a group of research students, sharing his expertise and nurturing the next generation of medical physicists. We are privileged to have him here today to share his insights on the uncertainty of issue in imaging registration. Please join me in giving a warm virtual welcome to Dr. Adam Yu. So, Adam, it's your platform.
Yeah, thanks, CS and Kathy, for kind introduction. Obviously, a bit longer than what I expected. So, hi everyone, I'm Adam. Let me share the screen first to check that everyone can see this. Here we go. Can everyone see my screen with the laser point?
Yep,
Yeah.
there we go.
Yeah, sure. I'll move this Zoom control panel to the other side. Okay, that's good. Yeah, I'm Adam from Melbourne, in Australia. So yeah, I work in Peter MacCallum Cancer Centre. Anyone doesn't know, or Peter Mac is in Melbourne, the primary public hospital affiliated with the University of Melbourne for radiation department of radiation oncology. Oh, someone's drawing on my screen, which is good to interact together. So I'm happy to answer a question along the talk. I slightly changed my topic to make it more relevant and interesting. So initially, it was issues and uncertainties in image registration, but I changed that to be, so click that one. So image registration in radiotherapy and motion management. There we go. I'll start. So pretty much all those video clips here is summarizing what I want to talk about. So the concluding remark first, because image registration is really the embracing platform and the radiotherapy, the entire treatment chains in radiotherapy. So I'm not sure how I can delete this annotation here. I'll just keep going. Disclaimer, yeah, the research and training agreements with the variant. So some of the slides here as used for the variant motion management workshops we've been running once in each quarter, every 3 months. We started end of last year. So a bunch of agreement for the research grants from our Peter Mac, and also the license agreement in terms of the motion platform with the CIRS and nuclear. So what I want to present here, and most of the examples heavily focused on the Eclipse, but all those principles are applicable to all the other clinical solutions. So we want to cover image registration fundamentals to start with. So we're specifically not covering the elastic or the mobile image registration. A lot of it will be covered by the more exciting talk will be covered by Ben. And then so we'll cover here strictly the rigid image registration, its applications and its issues, how we can deal with when we do our radiotherapy here. And a lot of role of multimodality imaging and registration and its issues and limitation, how we can deal with and cope with. And then we just really heavily focus on to gain understanding with this image registration tool and the requirements, specifically in terms of the motion management and combined with stereotactic radiotherapy, but also is that the principles applicable to fractionated cases as well. So I convert this learning objective into 4 questions. What are the image registration, the basic, the definitions, and what can you do with the image registration tool for motion management? What can really go wrong? We really want to know this and tackle when we have this what can go wrong examples. I got a bunch of examples here to go through and how the image registration is used in motion management of radiotherapy. So to start with the basic, to be on the same page, what is image registration? So by its definition, it's all about finding a spatial transformation between 2 given image pair. So I can see that the people use 3 different pairs of terminologies. Someone says secondary image is matched to primary. Someone says moving image is matched to fixed. And the Eclipse variant solution is saying source image is moved to the target image. Or in radiotherapy, someone says secondary to primary is the most relevant one. Or to me personally, the moving image matched to fixed is a most generic term used. But unfortunately, in variant, we use the third terminology, the source image to match the target. Regardless, any piece of terminology you guys use, everyone can understand all. So it is all about iteratively move one image to the other to maximize or to minimize the similarity. This is an example here using image rigid image registration case. So that's the definition of image registration. But probably one of your doctors will recall, or can you fuse those two images? And then we tend to intermix those two terminologies, image registration and diffusion. But strictly speaking, image fusion is different to image registration. The fusion itself is all about the blending exercise with the given image registration. That is, with given the image registration matrix, we want to blend those two images. That's it, image fusion. But in reality, we tend to intermix those two. No one really get bothered about those two terms used at the same time with the same meaning in the context. So you got the many tools here, the structure toggling and synchronize window level. The moving and split window, this is one of the examples here. Then we have a subtraction map and then the flicker map, etc. So those are the bunch of tools everyone familiar with to blend those two images with given image registration. So that's the definition. So when do we need image registration and motion management? Basically, this is my conclusion statement. Image registration is an embracing platform throughout the radiotherapy chains. So image registration is used throughout. So we start with the segmentation at the multimodality treatment planning for target delineation. Also during the treatment, it's used for every single patient for image-guided radiotherapy. And some of it will be covered. This is heavily covered by Ben with the ethos program in the following talk. So it's heavily used for adaptive treatment planning. And then also we can use that for the tumor response assessment. So that is throughout the treatment chain, image registration is very, very used and an upstream issue. So how we do the image registration, the most common example, you have those two images. For example, before you actually do all the contouring. So the good starting point is that we always manually match, not assuming that all the center of mass in your volume of interest is too far away. So we don't really run the automatic registration because this image center of mass is too far away. The automatic registration doesn't give the good results. So we manually match center to center roughly. And then you think it's close enough and we hit auto registration in reality. That's what we do in clinical practice. And then with given auto registration, we refine. So via another secondary, the manual registration process. And then we do rely on what we can see. That is bony anatomy or any high contrast features, landmarks, and etc. The organ boundaries. So assumption is a low contrast region. And anything we cannot see will be moved together based on what we can see. That's the pre-assumption of the rigid image registration. But that pre-assumption doesn't hold anymore for the formal image registration. So it's not only the intensity based, it's for example, an Eclipse solution from the variant. It's, I believe, similar for all the other, most of the clinical solutions that have a point-based image registration is possible. They're a very good example. In PDMAC, pretty much all prostate patient has 3 visuals. We can define those and then we can do point-based image registration as well in conjunction with image intensity-based registration. So it can give some mean and maximum error there. So you have a good confirmation that something we cannot really see here inside, and we have the high visual, high contrast features such as visuals we can rely on. So some very quick theory in the automatic image registration. I'll call it the black box here. So we don't really know much what's going on inside this automatic image registration engine. So under the hood, there are, so I can use this the terminology borrowed from the IDK. As I mentioned earlier, they actually took this pair of terminology here, moving and fixed. The moving image is a secondary image that match to the fixed image, which is primary. So I intentionally intermix those different terminologies here, so everyone get familiar with those differences. So those are the inputs. And the first component is interpolator. Basically, those are the pre-processing anything before actually do image registration. For example, you selecting the volume of emitters and resampling and apply the noisy filter, etc. And the metrics itself, it is a scoring system, right? And depending on what kind of image modality you have a different metrics you to score. And optimizing the third component is really purely the mathematical function, how you can shape the iteration of each step. I'll show you each examples with the actual practical cases. The transformation itself is that you can do 3 degrees of freedom if it's IGRT for the treatment, and if you don't have the couch kick applied in your treatment protocol, we only do the 3 translation. Or if you apply the 3 translation plus rotation for treatment, we limit it to 4 degrees of freedom. Or this is only for purely for planning. Or if you have a robotic couch in treatment, you have 6 degrees of freedom or rigid. But this can be also deformable image registration with different algorithms, right? So let's move on. So the way we do automatic image registration is very similar to the way we do optimization. So analogy with optimization function, y-axis, the cost function is replaced with the image similarity penalty or the simulated cost function. Then you iterate that, and most of the treatment planning systems or image registration software is configured to minimize this scoring metrics. So once it's reached to the global the minima, and then it stops. So that gives the best image registration to produce the transformation metrics between the 2 images. So this is an example of those 4 components. I want to show the real examples. These are the Eclipse under the hood. So actually, it can be configured by the users, but the default is the auto matching it here. And each of those aforementioned 4 components is slightly different terminologies, but pretty much the same concepts here. The first one, pre-filter they call, but it's basically pre-processing interpolator. So you can have different filters. You can resample, matching the voxel size of one image to the other. And similarly, the index is a scoring matrix. In Eclipse, they have 3 different metrics depending on what sort of modalities you use. For example, mutual information is the most common one. It's being used by default. So it can cover mono and also multimodality imaging, for example, PET-CT to CT. But cross-correlation is used for the same intensity level definition. For example, cone beam to CT or CT to planar CT, etc. And the pattern intensity is not commonly used, but it works better than the other 2, especially when there's a low contrast images like nuclear medicine image or ultrasound image, angiography, for example. So that works the best. So it's got 3 or 4 different options in Eclipse example. And the third component, optimizer, is just a purely mathematical function. It's really to shape out the way how we can go throughout the iterations. So with simplicity mindset, I imagine this is like the coin donating box here. The shape of the surface really determines the coin, what's the pathway trajectory of the coins, how it goes. So this is the analogy of this optimizer. The shape of this mathematical function really drives which direction it goes to the next step of iterative process. It's got different functions. So the final one is the transformation metrics itself. So we can really click which one to use. In the pre-planning process, all of us pretty much, we use 6 degrees of freedom for rigid image registration. So in a nutshell, that's under the hood for 4 different components for automatic image registration. For deformable image registration, rather than using those 6 degrees of freedom, and every single voxel can freely move around independent to the adjacent voxels. So also you can set when you stop the next iteration, if it's captured to the global minima, we really don't want to wait to waste time. So we can set this internal resolution also, what's the tolerance value to stop. So the automatic registration is, of course, by default is intensity based, and then a whole image. Also, you can using the volume of interest as a part of the pre-processing at the interpolator step. And then most of the systems, it has the option you can have, if there are any given the structure sets, you can actually use that focus around those given structures rather than in conjunction with the given rectilinear volume of interest box. So image fusion registration is often complex. There's a lot of patients has multimodal images, the multiple study sets and data sets. So it's really important to know what sort of the image, how many images we're sharing frame of reference. Typically, when you're sharing frame of reference, it's a bunch of images taken in the single setup. MR image T1 and T2 data set is a good example. Also, DIBH. Breath-hold scan is free breathing scans, and 4D CT all together is another example of sharing the frame of reference. So the properties of image registration really important to know. So it's a DICOM conformance statement is in place for anything FDA cleared the clinical solutions. So it has a DICOM image registration its own DICOM object. So it's the mean to score it's given metrics values here. Also, it's coupled with its own UID as a property. So what can we fuse? And then you need to understand your own system, or can my system can deal with the 2D, 3D imaging, like a two orthogonal images. Those can be fused to 3 volumetric images, or 3D is the default, but can my system fuse do 3D image to the 4D data sets, or 4D data sets to 4D? Is it really available? So in Eclipse system, the 4D image fusion is not available, whereas the Elekta system, it does allow. So the understanding what kind of images, also what kind of functionality is there in case the 4D movie sets, you can create the average in maximum intensity projection or minimum intensity projection can be created in your CT probably, or in your treatment plan system. So when you talk about image registration, what to consider? So the first document we refer to is a TG132. It's now more than 5 years old. But there, I won't go through all those details. But in a nutshell, the sources of error is like 3 different components there. The input is the data set itself. This is a good example here with a limited field of view, and also limited, of course, resolution of voxel sizes. And then second source of error is during registration, the process itself, the way we do image registration. If you focus on a particular area, but given image registration matched to the whole skull, probably it has an error in where you're interested in. The output has also is another source of error, the way we interpret the given image registration or incorrect use of the registration. So the case 1 here, the issue, the fusion issue, you can see what's the issue here. If your volume of interest outside is a field of view, it's no matter how good image is inside here, it's not. It's kind of rubbish. So case 2, what can go wrong, or what to consider? It is the MR, is a typical one. It looks beautiful in one particular plane, and you look at the other plane, and often it has a coarse resolution. A lot of us, there's a limited access to MR data set in order to reduce the reconstruction time. The image resolution is not always as good as the CT for the MR data set. A good example here is spacing is a 0.5, 5.5 by 5 millimeter in this superior inferior direction. And the MR slice interleaving as of end results is same. When you look at one particular images, MR, the well-known is a superior soft tissue contrast, but not always good when you look at a particular plane where you really want to, what really need for given target delineation. So another typical example for image fusion, what can go wrong? What's the trouble? And a lot of patients have high density implants, and it's a good example here of MR and CT fusion. But imagine this is pretty much the prostate patient. We want to delineate the prostate here, or it's a striking artifact from planning simulation CT. What can you do with it? Another example here, it's so common we deal with on a daily basis. In this case, another solution can be you take the 2D orthogonal images. It's really less susceptible to the high density artifacts. It has a better imaging, but you can detect the 3D fiducials from 2D orthogonal images. Then you can fuse those to the planning CT. So you can define all the markers really, as a surrogate for the target. This is another classic case. Then look at here MR. We think those are the fiducials here. And then it seems like they're physically impossible, not plausible, because the one marker is actually fixed, but all of a sudden the other marker seems like moved from the one side to the other. So what's going on here? It ended up being we are not really matched to apple. It's apple to pear, for example. This one is in classification, and the one is really the fiducials. In MR, it's the fiducials here. And those it looks like seemingly the fiducial, but ended up in reclassification. So another good example when you talk about image registration is issues in the PET-CT fusion. But we always assume PET-CT is sharing frame of reference. What that means acquired from the PET-CT scanner in the single setup. So we really tend not to check that it's given default fusion, but actually you can see here. If the patient moved between PET and the CT component acquisition. So it's really lack of any immobilization while the patient actually moved. And just another example, you have a 2 consecutive PET CT, and you see like PET and CT, the SUV is really registered. One is registered well, the other one is misaligned. I'll tell you in the coming slides why and how it can happen. So in terms of motion management, is when it's a head and neck, probably it's fine if there's not moving part internally. But whenever we talk about the 3D PET CT, which is most common, and not many people have access to 4D PET CT. So I'm talking about here the 3D PET CT. The 3D PET CT is good to detect, to know where the lesion is, but 3D PET CT is not good enough for the moving lesion to when you try to match the planning CT for target delineation. So unless the 4D PET CT is used, motion blurring is present, right? The planning CT is when you look at the CT of the moving part, for example, liver here, it's always a snapshot of the entire organ excursion. Whereas the PET CT is a long acquisition by its nature. So when it's acquired during the free breathing, it's really capturing the entire tumor excursion, for example, from here, respiratory motion. Right, so it's all about then what's the scan time. The planning CT always is snapshot in the 3D CT, whereas 3D PET captures entire tumor excursion, right? And there's also the coupled with the quite coarse resolution here. So when you try to match a few register images PET CT to planning CT, you kind of it's not matching the same lesion by its nature, because the 3D CT is a snapshot. Anywhere, any breathing phase of the 4D CT. So the PET is usually good for detection. We want to know, especially with the moving lesion. But I strongly recommend consider not to use those for the target delineation. Right, I'll show you here the example. So 3D PET CT is always can be misaligned, or by luck it can be aligned well. But it's by its nature, the PET is really good, but the 2 consecutive 3D CT can have a different snapshots, or a different position of the respiratory motion. So the misalignment, the 3 different reasons can have the same symptom as a 3D PET and a 3D CT. And then the CT is a snapshot of a different part, as I mentioned, or the 3D PET and they have a 4D CT, and it actually has all the multiple phases of the respiratory motion. But if the 4D CT has the motion artifacts, and you can also have a misalignment, right? Because it doesn't really truly capture the entire motion. The true solution for 4D PET CT registering to the 4D CT, if there's out of synchronization in the respiratory breathing trace, it can also have different spots in 2 consecutive occlusions here. So the take-home message for PET-CT to a plain CT registration, the 3D PET-CT is good, for example, head and neck or the bony parts, but it's not really good enough for the moving lesion, pancreas, kidney, and the liver, for example, for target delineation. Because of this reason, the limitation in the 3D CT component, which is a snapshot due to the short acquisition. Now, this is example. So this is a 3D CT here, acquired from the free breathing. So what that means, 3D CT here is any part, a snapshot of any part of the breathing motion. And the free breathing 3D PET, because it's a long acquisition, is acquired during the tumor excursion. So the PET component is capturing the entire tumor excursion here by the magenta, but actually pink is a contour of the same lesion on the PET. And the concordance index or dice index, you see the overlapping index scoring is pretty low. And so the same patient we acquired with the 4D PET-CT. So the 4D CT with a maximum intensity projection capturing the entire tumor excursion. By its nature, the PET component it does. So it shows a good excellent agreement compared to this case of the same lesion of the same patient. It really highlights the limitation of the 3D PET-CT registered to 3D plain CT for target delineation purpose. This is another extreme examples here. The free breathing, there's another same patient, another patient that you can see from the distribution of the SUV from the PET, it kind of staying longer time in the exhale and the inhale for both ends breathing phases. There's staying less time in transit intermediate phases. And this 3D CT is capturing only the snapshot, the one particular phase. In this case, is at the inhale phase, and then you see the overlapping index pretty poor. And then of the same patient, we have the 4D PET-CT, and the 4D CT component and 4D PET component both are capturing the entire tumor excursion. It's really matching the perfectly. So that's the issues, limitation you might really consider. And then moving on to the last question, how image registration is used in motion management or radiotherapy. This is the main highlight, the main part of this talk. A good example is the liver. This is our plain CT immediately. You can't really see where the lesion is. Often, that's why we want the multimodality imaging, like MR or PET, nuclear medicine imaging to detect where the target is. And then somehow we can guide it by those secondary image data set. So interesting parts. That's why in PDMAC, we use plain CT or the triple phase contrast scan, which the beauty of that, we cannot see plain liver lesion here. So we do the same exactly treatment setup. We have the contrast scans right after non-contrast plain CT here. So the way it works with the liver is very unique the organ in a way that approximately only the 20% of the blood supply is from hepatic artery, and the other 80%, the majority, is getting from portal veins. So it's a dual duct, the organ to get the blood supply. Whereas that's the healthy liver. Whereas the primary liver, the HCC, also the liver met, so the malignant cells in the liver are actually getting the majority of the blood supply only from the hepatic artery. Therefore, it has the contrast enhancement between malignant cell and the healthy liver. The surrounding healthy liver here. That's the plot of the HU when you inject the IV contrast. And the particular amount, this is the clinical, most commonly used the contrast protocol with the 3 milliliter per second. That's what we use. Then you see the aorta there, and then the HCC, the primary the liver cancer, and also healthy liver surrounding. So it has the contrast enhancement there. So it's particularly wash-in phase. There's a subtraction of the contrast enhancement between the healthy liver, the green, and then the tumor in the liver. So it has the contrast enhancement difference. The wash-in phase we call the arterial phase, and the wash-out phase here is the portal venous phase. So it has a tiny gap here, about 20 seconds, and each of the washing arterial and washout portovenous phase that's long enough to acquire the short 3D scan, which takes typically 10 seconds or less. So in Eclipse, that's an example of that's what we call triple phase contrast scan. So we start with non-contrast planning CT, and then we take, and then wash-in phase, and the washout phase, arterial and portovenous phase retrospectively. And so we ask patient patient breath. And so we got, this is beautiful case, and the 3 consecutive scans done in the same session on the same study set is showing frame of reference. So it's by default, it's fused. The patients are holding the same position. So this is the arterial washing phase. You can see where the lesion is, and portovenous phase here. So all triple phase contrast scan was done with exhale breath hold in PLMAC with the exhale breath hold rather than deep inspiration for a liver or any GI around here, because when you breathe out, all air is out, it's far more reproducible than breath in, because you can have a different amount of breath in phases. And so this is our default protocol for our motion management for the liver, for example. So the all triple phase images is acquired in the same breath hold position. Therefore, all 3 images registered well by its default. So it's a very interesting image registration scenario to play with. So what can go wrong here? So typical the sequence is before we inject in the contrast, we ask patient to breathe out and hold as it takes 10 seconds or less. You can see how long it takes there. That's x-axis in seconds. And then we ask patient to breathe normally to give us some break. So we acquire the planning CT without any contrast. Then we ask once the contrast is injected, we ask hold, but the patient actually held right above the gating window, the threshold here. So and this was the breath hold, so it's good, but probably we need to break the fusion and re-register with the wash-in arterial phase. It was a mid-phase breath hold. And then washout phase, the patient had a short break and then acquired a breath hold, but inhale breath hold, near inhale breath hold here. So this is a typical scenario of what can go wrong in triple phase contrast scans. In contrast to very different to the previous good case, a 3 triple phase acquired in the same breath hold position. Well, this case, as expected, and then we have different liver dome positions here. Liver dome itself in this particular case is really a good surrogate for the target itself, because there's acquired a breath hold in a little bit of inhale here that they're actually pushing down the liver dome. Therefore, it's a mislocate registered compared to plain CT. And then it gets worse for the portovenous here, right? So what can we do? And but one can ask, is my treatment planning system can break the given default fusions? So in Eclipse, you can really copy and paste and apply the new frame of reference, its own coordinate systems, and they create a new data set. So you can actually have you can create a standalone registration. So this is a copy, the new data set with its own coordinate system. So we create a new standalone registration match re-registered to plain CT. So you can see it's better matched. So that's typical process, really interesting case in terms of image registration, how it's used for motion management in radiotherapy. Hope it makes sense so far. So as you can see, I'm going through from the treatment chain from a simulation stage and the contouring and how it's used for the planning and image guidance for the treatment. And this is a really extreme case. This is a 3 lesion, our SABRE stereotactic body radiotherapy cases. So it has 3 lesions. So I'll show you where those 3 lesions are. But you can see the planning CT exhale breath hold and the portovenous washout phase. So you can see the superior and inferior, the motion is quite different. And one is elongated, more elongated than the other one squashed. You can see between planning CT and the contrast, the washout portovenous phase contrast scans, right? You can see that throughout the liver it's misregistered. Because we have the 3 lesions here, What that means for the image registration, we need to create 3 separate image registrations, right, to match locally around each lesion. So it's a really good practice is not to use default registration and by blending at just looking at contrast image, but if the structure set is still associated or attached planning CT, and then if you have the wrong registration to start with, and that you unintentionally delineate your target in the wrong location in planning CT. So your doctor or clinician may have to revolume lesion with a new registration. That's the worst case scenario. We really try to avoid that, right? So in PMX, our default protocol is we ask our clinician to directly contour on contrast CT. Okay, so not on non-contrast planning CT. All 3 target lesions are delineated directly on the contrast CT here. So now we know which part of the liver to focus on in order to create its own image registration, focusing on each of the 3 lesions. So therefore, in this particular scenario, there will be have to be the 3 separate image registration files, focusing on each of the given GTV location. So therefore, we have portal venous where 3 targets are contoured on, and then we have 3 different registrations here matched to planning CT. This is a typical example. What if we use the wrong registration to transfer this target? So you can really go to a completely different location, right? This is really the worst case scenario we try to avoid. So, and then we have, that's a good case, okay. And we have 3 separate registrations used to transfer the target of the given target with the correct location here. This is a really good case. And this really highlights the importance of image registration, how it's used for the target delineation, okay. So now, so far we covered image registration for simulation and image registration for target delineation using multimodality imaging. And then now we move on to planning, okay? So free breathing case, this is our one of the clinical trial patients for, it's called the master plan under TROP. So this is really pancreas. There's a bunch of fiducials inside. It's a 5 fraction, a 40-gram 5 fraction pancreas stereotactic radiotherapy clinical trial. And the 5 fiducials here inside, you can see that's a perfect surrogate of the target of the kidney. The pancreas, because we cannot see the pancreas itself, because all those fiducials are inside pancreas tumor. So in this case, we really want to limit the respiratory motion, the organ motion. So mainly not only the target, but also adjacent OARs, organs at risk in this GI area. It's a duodenum, stomach, small bowels, and large bowels, etc. The most radiation sensitive organ. Really works doing the motion management here. So you can see the full motion here is the tumor excursion. The extent of the tumor motion is nearly halved in this exhale gating between the 30 and 70%. So this is gating window. You can show between 30 and 70. In this case, we also applied this planning CT, no contrast, and the arterial portal venous contrast. We apply at that breath hold level because we can see it's a breath hold nice and crispy edge of the target as well as surrounding organs at risk. So arterial phase and nice and breath hold here. So you can see the level of with really contrast enhancement, a level of details for the target itself, with the fiducials, and not also the surrounding healthy organs here. So IGTV margin, or ITV margin, really adding the internal motion within this gating window, which is about 5 millimeter, and we also put additional 5 mil at the PTV margin. So this is another image registration exercise. And also we have not only the target have the ITV, also the surrounding organs at risk also moves within the gating window. You can see from here, it also have the ITV and like the concept, the PRV about 3 millimeter from each the intact organs at risk. So I'll use this example in the next step for the image registration on treatment. The image registration. Now we're moving on with we've gone through the simulation and also the target delineation with the motion management. That we created the gated the planning images, and then we're moving on to the treatment for image guidance process. So in this case, if the liver lesion is attached, that's extended to the liver dome itself, then the liver dome is a perfect surrogate to match to, right? So how you can match? The extreme scenario, we have a breath-hold image and then a free breathing image. We also use this density probability function. Yeah, it simply is a line profile. It's a fancy term for the line profile for the matching. You can see it's a sharp ramp up here from the liver to soft tissue. And you can see it's kind of the crispy edge. I assume that will be breath-hold images. For arterial contrast image, you can see the free breathing. They have a very slow slope from the lung to the liver soft tissue because that really has the extent of the motion about the 2.5 centimeter here. And I'll play this. This is another example for the image registration challenge for the moving lesion. What all we want to confirm is the after 40 cone-beam CT is matched to 3D average planning CT. After registration is done by moving the couch, online matching, we want to really overlay the contour, a target, IGTV, and then actual tumor is moving inside. The tumor excursion really contained inside IGTV. That's what the final goal we want to achieve before we hit the beam on. So those are the examples of image registration during the IGRT. So what's wrong? This is our previous case, the master plan, the pancreas case. We've acquired the cone-beam. So what's wrong here? It's a 5-fraction treatment of 40 gray in 5 fractions, so 8 gray per fraction. And those are planning CT with all the contours, the targets, as well as the surrounding OARs and its PRV structures. And the duodenum is an example here. It's quite overlapped with the target. And what's going on here? Fraction number 1, it looks like nice, and I can certainly see all the organs at risk in place, similar as the planning CT were matched, we treated. And the next, the fractions, something went wrong here. Can anyone really pick that up? So what's going on here? You can see the answer is that the duodenum, which is overlapped with the target here, is actually kicking in towards the target here. So we actually had to abandon the treatment. Right. So and after the medication and the new fasting is done, and you can see that all the most sensitive adjacent OAR, which is a duodenum here, is overlapped with the target, is moved back to the planned position here. So it's really the IGRT will have a good value of having volumetric image matching. So this is a really cone-beam IGRT example, how the image registration well utilized. And then now we go to the treatment. So image registration during treatment. So this is a variant solution. It's called triggered imaging. We can have a synchronized KV beam with the during the MV treatment. If the tumor lesion, the lung lesion floating around in the middle of the lung, we can capture the KV images here during the beam on here. You can actually see that, and they're really good assurance that we are hitting the right spot even during the treatment. This triggered imaging it can be applicable to any moving lesion such as lung, liver, and pancreas, and prostate, but it with a different ways of utilizing the tool. This example for the lung, and had a bunch of surgical clips inside the liver. You can, rather than the markers, we can actually contour that out, and then we can do the triggered imaging. In this case, it's the breath-hold treatment for the patient. And also had a residual the structures from TACE or the SID, any the liver treatments, and they had a lipidal is a good example of the residual treatment of the ablative technique. And we can actually use those structures as a surrogate if that is inside or adjacent to the liver, the target. And another example, the triggered imaging, we can create those marker here. So we can define those markers of, because those three fiducials are inside the target, we can monitor throughout the treatment. So this is the triggered imaging example of the given the pancreas, the clinical trial patient we showed in target delineation is a free breathing gating treatment. We also showed the cone beam example. Let me play. So this is real-time images. As you can see, 30 to 70 around exhale, free breathing gating treatment. There are 5 fiducials here. It looks like more than 5. They have contoured a bunch of the fiducial as a single contour. During treatment, we have each MU-based triggered imaging. So after a certain given MU interval, it captures 1 kb imaging, so we can really ensure the target is in the intended position throughout the treatment. A really good tool. And this example, the first triggered imaging here, first fraction, we captured nice, and we really ensure that we are hitting the right spot throughout the treatment. And the second images and the different angle you can see from the snowman. And so we ensured really it had a good treatment. But and then you can imagine this can happen anytime. So we're thinking in the external surrogate, it's hitting the right spot within the gating window, but internally, and actually this target surrogate, which is fiducial, is moving away from intended position. So it is really the value, the ability to capture potential mistreatment, partial mistreatment, right? So once this, the triggered imaging show that the mismatch here, and then we acquired this much, this frequency is the same as 3.5 millimeter. Is actually a quite big misalignment. So we did a spotlight with a quick cone beam, which is a partial volume. It's only a 200-degree cone beam, so it's quick. Also, you have a less scattering, the artifact, because of the field of view itself is less, but it's big enough to see where we want to see. So we actually moved based up, did online matching based on this mid-treatment cone beam. And we happy chat after this mid cone beam, we ensure this triggered imaging also showing is that fiducials are back to the intended spot. We continue completed treatment. But happy chat. So this is my last slide. So again, our concluding remark, the concluding statement, image registration is really the upstream issue throughout the radiotherapy chain. Also, the embracing platform used throughout the radiotherapy chain, starting from the simulation all the way to IGRT, and even during the treatment. Also, we can use for the follow-up images. Some of this adaptive technique will be covered by Ben. So image registration is really crucial. It's upstream issue. If it's wrong, all the following the subsequent steps are wrong. So I recommend you better spend more time in the upstream issue rather than the downstream issues. So I'll stop here, and then happy to answer any question after Ben's talk.
Thank you, Dr. Yo, for your enlightening talk on imaging registration and its impact in radiotherapy. We truly appreciate your depth, knowledge, and the insight you have shared with us. And I have noticed there are around 6 questions to your talk. So I will read the questions and then turn to you to answer the question. Is that okay?
Yeah, I can see that questions here. Sorry, are we doing the Q&A now or after Ben's talk altogether?
I think we're going to do the Q&A now, Adam, and then that way you can probably head off if you like after.
Yeah, sounds good.
Okay, so the first one is from Debolina. He asked you, did you compare the imaging fusion and the registration technique with only one TPS, Eclipse, or any other TPS? If yes, then what are major difference between these techniques?
Yeah, that's a very good question. Indeed, we do have multiple treatment planning solutions in our department. We used to have the Monaco, now we have the Elements, or I plan the Brain Lab solutions.
Okay.
And then we have the research version for the research, and we have an image registration contouring dedicated software such as MIM and the velocity. So we have a bunch of different solutions. It's got its own characteristics and pros and cons. For example, the brain lab, the intracranial stereotactic solution. And I hope everyone is aware of that. Or iPlan or Elements is a brain lab solution that, as of today, the current most up-to-date version of the brain lab TPS, the Elements, it cannot hold the given frame of reference from the scanner. For example, PET and CT from the PET scanner, and Elements that see those two components as a separate, independent image data set. We have to fuse it, which is really not ideal. We want to use default registration given from the PET CT scanner, but Elements doesn't handle correctly the given shared frame of reference. Same for the T1 and T2 MR images. We had to manually fuse it again. It doesn't read the default registration. So you have to know. That's a really good example of knowing the limitation of what's the characteristics. And some other example are velocity or MIM. Unlike the Eclipse, it can freely make its own registration. Also, it's keeping its own DICOM, the frame of reference. So it can use both. It has a greater degree of freedoms to handle images.
Okay, so we move to the next question from the same one. So for the list fusion done with only CT and MRIs or with both CT and PET imagings, as PET imagings are usually larger in numbers compared with MRI imaging numbers.
So is it a statement or questions?
I think he would like to how many numbers of the imagings between CT and the PET, and in his description he say PET imaging has larger number. I don't know, is that exactly? And his next question is, what are the slice thickness chosen during the scan? I think in your slides you mentioned that for your PET the imaging slice is around 4 millimeter. Is that correct?
Yeah. PET component, it's got gamma camera, and then it's got its own limitation. It cannot really go down like a CT or MR. I think that's a good question. So that's MR to CT fusion or PET CT to plain CT fusion. It really depends the multiple factors. Okay, so it's depending on body site. For the neural case, the MR is a crucial, right? And head and neck case, the PET CT is pretty crucial. For example, spine, we want really MR. We want to define the target malignant target as well as the spinal cord.
Okay.
Yeah, so it really depends on which target body site we really want to treat. Also, it's coupled with your accessibility. If you have radiotherapy dedicated MR simulator, we pretty much want MR for everything, right? Okay. Unfortunately, we don't, and we have pretty limited access to MR, but we have a lot more freedom. We have a good access to PET CT, but we are very PET CT strong research and clinical science. So a lot of patients, we have a PET CT, more PET CT than other institutions probably. So that's another situation. Also, the medical insurance, and if we recently it's covered the whole body PET CT now is covered by our medical insurance. Yeah. And so a lot of patients are allowed to have that without extra payment. So that actually governing the factor as well. So the number, the frequency, the PET or PET CT or MR, or which one to choose multimodality imaging, really depending on the body size, ideally, if you don't care about money. Okay. We want both, but as I highlighted, the 3D PET CT, because not many people have access to 4D PET CT, right? So 3D PET CT is quite limited. We need to be cautious to directly use that for target delineation if the target is a moving region. Okay. Okay, I see. So we move to next one from Ray Kuma. Okay, he or she asked, how
imaging fusion and the imaging restriction are different process because the end result is just to match the matrix.
Yeah, that's right. As I showed in the presentation, hopefully it's recorded. It's saying we tend to intermix those terms, but to set up the scene and to be on the same page, the correct page, strictly speaking, image registration is what you refer to, creating metrics, which transformation metrics through the iterative process of matching the two images. But image fusion, strictly speaking, those are the blending exercise. That's the fusion. But no one cares, to be honest.
Okay.
I also tend to intermix those terms. I also ask my therapist, can you fuse those two images? Actually means register two images. Yeah.
So the reference imaging is from the CT, the pre-contrast CT imaging, right?
Most of cases in radiotherapy context, yes, the planning CT is the primary image, right? But
Okay.
if it's a like adaptive case, Ben's going to talk about also in assessment with the retreatment cases, it comes from probably the previous course number 1 planning CT might be the secondary image, right? As a node image to match to the new image.
Okay.
Yeah.
Okay. So we move to another one. What about breathing techniques during scans? Whether free breathing or breathe hold technique used during scanning?
That's a very good question. It can be another 1 hour talk in terms of motion management. So it can be either we have our tree, the process, a patient can hold. What do you mean by patient is capable of holding? Is patient need to be able to hold long enough. If the patient can't hold long enough, that's a good indicator. It can't be reproducible. But also that when you in the gating window, it should be consistent, right? After those 2 factors. So if you can meet those 2 factors long enough, patient can hold or hitting the same spot internally, then we consider that's breath hold capable. And we prefer breath hold, but not all patients are capable of doing that. So the free breathing gating is always the option. So, and otherwise the free breathing gating also not hitting the same spot in terms of internal liver dome position, for example, and that we consider that's not good candidate for free breathing gating either. So you might need to apply abdominal compression, for example, still free breathing, but shallow breathing, forced shallow breathing, or you can have active motion management. So we have those tree protocol. We do pre-simulation markup process to filter out which method is the best for the given patient.
All right. So the next one is, do you have any study in calcium breast cancers or just breast cancers?
Yes, we do a lot of stereotactic, SBRT or SAVA. For breast, we do DIBH for pretty much all patients using the therapist guidance. But for motion management, it's more crucial for stereotactic hyperfractionating, also SIV treatments nowadays. And those we do a lot of DIBH. Also, the central lung case, similar as breast, we do deep inspiration breath hold in order to create more space between central structures such as heart or bronchial tree to the lesion.
Okay.
We do a lot of motion management, image registration on that. But the breast, probably the PET CT is pretty useful. Right?
Okay, so I think this is the last one. So as a practice in your department, you use an ITV? If yes, do you define clinically?
Yeah, the ITV means to capture entire tumor motion. So for the lung case, we use a MIP to define ITV rather than rely on PET. Right, as I explained why PET cannot be used for target delineation, only for target detection. Yeah, ITV is a breath hold. There is a minimal motion. So the breath hold, there's no ITV, but like the one shot free breathing gating, you need the ITV to capture the residual motion within gating window. For the pancreas case is an example. There's still motion, but not as big as the full motion, right? With a free breathing gating or an XL. So in that case, you still need ITV there. So that's actually used for IGRT structure overlay to the 40 convex CT, for example.
Okay, very interesting. So thank you, Dr. Yo, for addressing the questions and provide valuable insights. We truly appreciate your time and the expertise. Yeah, thank you.
Yeah, I'm pretty sure that the upcoming talk is a lot more interesting than this.
About that, clearance registrations are still a developing space.
Okay, so now it's my pleasure to introduce our next distinguished speaker, Professor Ben Archibald-Heeren. I hope my pronunciation is correct.
It's a different name. That's fine.
Okay, Professor Ben is a leading authority in the field of medical physics and currently holds the position of group lead medical physicist for Icon Cancer Center. His contributions to the implementation of imaging restriction techniques in clinical practice are widely recognized. Today, Professor Ben
Is fine. Yeah, Ben is fine.
will advise on the clinical implementation of adaptive radiotherapy and discuss the current literature in this field. We will gain insights into the practice application of adaptive radiotherapy and its impact on clinical workflow and patient-specific treatment strategies. Without further ado, let's welcome Professor Ben. Yeah.
Thank you very much for the introduction. So let me just share my screen and just make sure everyone can see this.
Yes, clearly.
Okay, perfect. I'll get started then. Thank you for having me. I really appreciate the invitation. What I'm going to speak to today is the Ethos Adaptive Radiotherapy System, which is a variant system. And it's not to be confused with, say, the ViewRay and Elekta MRI systems, which are much more MRI-based. This is CBCT-based. And it's a nice thing to come into after Adam's talk because it takes advantage of some of those image matching techniques in order to produce the adaptive process. And so what I'll speak to today is the adaptive workflow, some of the limitations and some of the strengths of the current system. And then also a brief snapshot of kind of what the research is showing us at the moment. Now, just before I get into that, just to speak to Icon. So Icon is a radiotherapy delivery group for both radiotherapy and chemotherapy. We have a little over 40 centers now in Australia, New Zealand, into Singapore, Vietnam, and also China. And we have well over 50 delivery systems across the group now. Now, with respect to Ethos systems, we have two. So the Ethos system is essentially a halcyon system that has a new software back end as well that allows for the adaptive process. And we have two currently, one in Sydney and one in Brisbane, Australia. I really hope it doesn't do that transfer every time. Within our practice, this is just the Wahroonga practice or our Sydney practice. It does include the data from the Brisbane practice. We're well over these numbers now, but well over 1,200 fractions of adaptive treatments, and they're predominantly in prostate and prostate bed. And here's a few members from the team, including Dr. Amy Tsai, who's been the main clinician, and a paper that they produced on, or we produced, sorry, on prostate cancer adaptive radiotherapy. Now, as I said, the Ethos system is just a halcyon system, really, with some extra hardware in terms of computer processing power and some GPUs. But I'd hope that most of you should know about the halcyon system. It's a closed bore radiotherapy 6FFF delivery system with a dual MLC bank, and that just allows for a little bit better shielding than we see on the TrueBeam systems. Now, speaking to online adaptive radiotherapy, this has grown quite a lot, probably in the last 10 years. It originated earlier than that, but with computational improvements, it's started to really take hold in the last decade or so. And the idea of this is that we change the plan every single day to adjust to the patient's contours. You can see here on this image, this is an example of a head and neck patient where they've lost weight. And the top shows you the change in the contour and the incorrect volumes. And then if we were to correct the plan, this shows you on the bottom right how poorly aligned that is to actual patient treatment. This is a brief look at previous literature in the past. So we know that online adaptive has benefits where there's changes in the patient. Now it's either over many over weeks of treatment or if it's over days. So head and neck, usually you see this over a long period of treatment. Bladder and pancreas, it can be daily changes in the surrounding tissue. Now, if we look at types of adaptive treatments, there's really three different scopes, and they speak to different timelines. The offline adaptive is usually we're looking at a systematic change in the patient. So for a head and neck where they've lost patient over, say, a week, you're looking at timeframes of change over weeks, and it means because you're looking at timeframes of weeks of change, to implement that change in the plan, you're looking at, say, a day or two to get the adaptation completed. For online adaptive, we're talking about every day. So in this case, we're looking at how are the internal organs changing every day for the patient. Now, because we're doing it on the day, we have to take the image on the day. So that means that our process times need to come down to minutes because it needs to be quick enough that the patient isn't changing on the bed. And then real-time adaptive is another form of adaptation, and that's where we actually look at whilst the beam's being delivered. And so if we're looking at that, that needs to happen in seconds, and that's things like where we're tracking tumors within the patient, moving MLCs to match that. Now, if you look at the adaptive ethos adaptive system, it works in this offline adaptive and online adaptive space. At the moment, at least, it doesn't have any real-time adaptive, but I would hope that with changes in imaging systems on these machines, hopefully that might be something that can be introduced in the future. And I think it's an interesting point there, because that real-time adaptive is something some of the MRI systems currently do provide. So there's a point of difference there for those systems. Now, in terms of the adaptive workflow, how does it work? So this comes straight from TG 132, and this was their long process of how adaptation could work. And it's really split into the pre-aspect of planning, preparing for the adaptive plan, and then the actual on-machine component, or the adaptation component, which is where you're at the machine. So you can think of these as green is the prior and blue is the at treatment. And if we look at the ethos system, that's kind of split into the pre-planning or the reference plan, that this is the naming that Varian gives it, and then the online adaptive plans. And it's split into these two sides here, but I'll kind of speak through each of these components so everyone has a bit of an idea. So the first thing with the ethos system, it sits external to the ARIA system, but it does have a DICOM search connection. So we retrieve data sets, so our planning CTs and also our image registration sets get retrieved from the ARIA database and brought in. Now, once we've done that, contouring currently is done manually. I think that will change to mainly AI in the future. But in the current point, we contour these sets manually. But we also do have the option in this bottom right where we can, if the patients are being contoured in, say, Eclipse, we can bring that structure set across and import them into the ethos database. Now, after that, ethos works on a set of clinical goals. And so in the ethos environment, we set what is it that we want this plan to achieve every day. And you can see here, for example, with this P2V clinical goal here, we have actually the goals, which is what we'd ideally like to meet. And then we have variations, which is what we're willing it to go to without saying this plan is unacceptable for clinical treatment. And that becomes really useful in the adaptive sense, because sometimes the way the organs change means that what we could achieve in the reference plan might not be able to be achieved in a clinical plan. And counter to that, sometimes what we couldn't achieve in the reference plan might be actually achievable in the adaptive plan. Now, if groups are ever looking at setting up this, there's a whole bunch of white papers that were driven through some research with Varian. ICON was involved in this, along with North Sydney Cancer Centres and a number of European practices as well. In terms of optimization, another big difference, I think, between ethos and kind of more traditional algorithms or more traditional TPS systems is that those clinical goals you set up at that first point then get used as your objective function. So it's a very different way of optimizing. You can see here that there's a list of those clinical goals. The optimization priorities, if we use it that way, are determined by actually just dragging these little tiles up and down. And they can be in the most important section, in very important, in just important, and they can also be set just to report only. Now, what happens in the background of that is there's a new optimization kind of input system called Q value optimization. And it actually uses the original Varian optimizer, but it changes priorities based on the importance of this. So what it essentially does is places a human aspect of determining what the priorities the system should use in optimization. And it does it in this stepped process by optimizing top goals down. And then when it hits something that conflicts, it then re-looks at the values and determines which one should go up, and then continues on to the next stage as well. And so if you look at the bottom here, this is the process where the optimizer increases the priority of the red item until the goal was met. It then increases the priority of the green item until it's met. And then it increases the priority of the yellow item till it's met. But when the yellow item's met, it actually means that the red one is now no longer met, just because of the optimization process. So then what it does is retrospectively go up and increase the priority of that item again. And eventually get to a point where on the right here, all goals are hopefully met. Now, after that, it creates 5 different plans, actually clinical plans in the optimizer, and allows then the user to choose which is going to be used. Now, this plan won't necessarily actually be treated. This becomes the reference plan that the optimizer tries to match in all the adaptive fractions. So that's the blue box of TG132. So that's the pre-adaptation component that's getting everything set up. Now we move to the adaptive process, and I think what's important here is to know that Ethos is really designed to make the process as fast as possible. And if you think about how before I said there's no real-time adaptive, the reason it needs to be fast is because of that. So if something changes in the patient once you've imaged them, Ethos doesn't have a great way of dealing with that system. So what it has to do is make the process fast, and it does that by making the decision points quite quick. So if we run through this process, the first thing we do is we take a ICBCT on the Halcyon system, and as to, I think, kind of what Adam was speaking to before, where we go from that was to use an image registration algorithm, but in this case, an elastic deformable image registration algorithm. So what that algorithm does in the background is tries to set 3D space vectors from one voxel in the planning CT to one voxel in the ICBCT to then map across a synthetic CT. So the original planning CT is deformed. That's a synthetic to match the geometry of the cone beam CT. And the reason they do that is because of the HU stability of the CT and a concern that maybe in some cases the ICBCT might not have, I guess, correct HU, and therefore might result in an incorrect calculation. Now that might change. I think we'll see that might change in the future, and I'll speak to the research later. But that creates a synthetic CT. But what I want to kind of speak to here is, if you look at this bottom right image, this is where we know that a lot of these deformation algorithms don't do great in low HU contrast regions. So you can see in this bottom image, say the yellow contour is the bladder, but the deformation, you can see, hasn't deformed the bladder to the correct spot. So if you think of this yellow contour as probably what was contoured on the CBCT, so that's correct, true for the patient on the day. And underneath that, you can see the bladder is incorrect. Now, in terms of dose calculations, there's a benefit, I think, or there's a fortunate component to this, that differences in muscle and adipose tissue make a very, very minor difference in dose calculations, particularly in the MV beam range. And these algorithms do perform quite well in bone and lung and then external. So in terms of a dose calculation, it doesn't make a huge impact. Now, once that's completed, depending on the type of contours, some of them are propagated through that deformal registration. So again, where a voxel is considered a certain ROI or OAR organ, it's then deformed through that 3D deformation field to create a new organ. But then there's also a whole bunch of organs that Varian have created artificial intelligence algorithms to automatically contour. And the benefit of this is they're so fast and they can be adjusted on set. So this is an example of 3 organs that get automatically contoured by the AI algorithm. This is a convoluted neural network deep learning algorithm. And you can see this is the job it's done, say, for the yellow rectum and for the bladder and also for the bowel bag as well. So it does do a pretty good job on these data sets. A little background to that algorithm, as I'm saying, it's a convoluted neural network. It's based essentially, I think, on a UNet architecture. I'd recommend this paper if you want to, one of the original papers from Varian, and I'll speak to it later in the talk if you want to look into it deeper. It is interesting. But it'll be interesting because it's an area where AI algorithms are improving quite a bit as well. So there might be some areas for improvement on this long term. So once the influences or the AI algorithms are created and neuroelastic DAR is created, it uses a combination of those to create a structure-guided deformation. So I think, again, speaking to what Adam was talking to earlier, there's different mechanisms for creating these image registrations. And when he spoke to, say, point-based registrations, there's also the ability to use structures that have been contoured and you know are correct to drive that deformation. And so what that does is it deforms the initial structure-guided matrix to match those contours and then looks at the image matching after that. And a kind of nice representation here of this is probably this blue deformation map is considering both the underlying HU information matched to the new data set, but also where these influences are gone. And that just allows for slightly better accuracy in these deformations when you're looking at clinically implementing adaptive radiotherapy. A couple of little points too, and I'm happy to share these slides as well. There's a lot of information here, so I'm happy for these slides to be sent out after this, and you can kind of go through. Typically all of them have links to the different references, so you'll be able to follow these up yourselves if you like. But I just want to go back to I think maybe it was slightly touched on Adam's talk, but when you have particularly deformal registration algorithms, you have an image similarity term, which is what that image registration is trying to match or correlate. So the better two things are matched, the lower that image similarity score is. And then you have in deformal registration a vector field regularization term. And what that does is it controls all these arrows that are going between the voxels between the two images. It controls how they can actually get grown or developed or match. And so what that stops is it stops like these unrealistic things of like a bone flipping in on itself or anything like that. And then in terms of these deformations that are used for the structures, there's then a structure matching term as well. So that also goes into the optimizer, and that tries to make the surfaces of the two ROIs on the two data sets kind of match. Once we've got our influencers on, we've got our IRs on, we've got our targets on, and they've been checked. Now we can re-optimize the plans. So it produces a scheduled plan, which is what your reference plan was on your daily data set calculated. And then it also creates an adapted plan, which has been re-optimized on the day. So what that looks like is this. So here you've got, at this point, we've got the scheduled plan selected. So this is how well the plan matches to the scheduled plan. And you can see there's a couple of on the left side, which are scheduled, which are red. And because we've been able to adapt the plan, these objective functions that we had set up in the original part have come back into this plan, and they've actually allowed us to get a better quality plan for the patient. So you can see here that whereas our scheduled plan, which was our original plan, has all these areas that are red where it's failed the clinical goals, on the adapted new plan match for the day, it's actually much better and matches the goals. And you can see they're all kind of gone either into orange warning or into green approved for clinical treatment. And we can just switch between these. This is the reference plan and this is the clinical plan. You can see how things like your rectal dose is coming down, but your PTV coverage is improving. And that's just because you've made it specifically for that day. Once that we've selected a plan, we accept that plan. Mobius is used for QA in the background, and then we deliver it on set. Okay, so that's how it all works. Now, we're still in the first kind of phase of ethos, so I think as future versions come through, there'll be improvements, but I want to just kind of speak to the strengths and the weaknesses of both. So I think in terms of strength, it's fast. The way they've used GPU means that the process is really quick for creating these adaptive plans. The automated planning is usually very good compared to manual planning as well. It models the dose really well for these optimized plans. The AI contouring is very good. It matches human plans. And we're seeing from all these studies coming out that the daily adaptive planning does result in better clinical goal results for patients than the standard plan is. And the QA is really efficient. Now, limitations, there are still a fair few. So the model is not very good for small field modeling at the moment. We would never clinically use it for anything under 2 by 2 centimeters. So that kind of rules out stereo. There's limitations on how well you can train the optimization in terms of beam angles, and it struggles sometimes if you set 2 goals that are conflicting. You can't deal with that or deal with them correctly. There's limitations with the DIR because it's an elastic DIR. As I said, it doesn't deal very well with soft tissue. And there's no way currently in the system for when you deform all this dose back to your accumulated plan to really understand how well that DIR is going and if it has issues. And the other thing is there's no ability for us to create our own AI structures. But I do think that Varian are working on adding a lot more structures. So that might not be an issue going forward. And as I spoke to before, it doesn't have intrafaction motion or real-time tracking. And if you're doing something with a prostate and your bladder is expanding, if you optimize the plan to that, you probably want to make sure after the fact that it's not going to move out of that as well. Like, it's one thing to reduce your margins because you know where the prostate is every day. It's another thing completely to reduce your margins knowing that during the treatment that prostate won't move out of it. This is just some other considerations about what I think you really need to do if you're going to implement systems like that. You need to look at what algorithms are going to be. You need to look at what schedule and template you're going to use. You need to look at the different beam arrangements in terms of how long they take, how good is the quality of the plan. And you also want to look at the strengths and weaknesses of the OAR propagation and where AI contouring differs kind of from the manual. Now, the way you can do this either through simulations of ethos sessions or going through and looking at the literature and what the literature recommends. The other thing to think about here is that do you want to, so ethos takes a while to treat, probably 20 minutes a patient really. And based on your local regulations, does that require an RO to be on site? Because you're essentially making a new plan every day. So you really need to speak to, like, is it okay in your regulations that that plan is approved by, say, a dosimetrist or an RT rather than an RO? And this is something that we've worked on quite a lot in Australia in terms of medico-legal. So we're now at the point where we can have RTs make those decisions, but it's something to be aware of if you're going to get these systems. There's another thing of things like background stuff you need to know around, and that's like what's happening in the background of this optimization. So there's rings happening, there's like a large normal tissue structure happening, reduction of dose happening, there's max dose objectives in the background as well. And because they've tried to simplify the system, you can't really see that happening. And so that requires study and research to have a good understanding of how they're impacting your plans. The other thing is currently, though it's changing very, very shortly, the dose distributions in these plans assume conventional dose distributions, which is obviously a problem for stereo where we actually want really peak doses. So the optimizer itself is trying to limit the max when actually for stereo we want to have those really peaked high doses. There's other things to consider around deformation and AI contouring limitations. This is the whole workflow of what happens every single time you start an image on an ethos. So it's a really convoluted process. You need to know which registrations are going to which sections and are impacting which organs. And it just takes a long time to understand that information, or you need to look at the literature or papers like this here. The other thing that I was talking about is intrafaction motion. So this is a study, small study size. We've actually done more data on this now. But your intact prostates now take around about 15 minutes. That's from getting on the bed to finish. Prostated nodes, because the data set's larger and takes more optimization, tend to be a bit longer, about 20 minutes. And prostate bedded nodes around 22 minutes. Now, the problem with that is that a prostate and bladder over that 20-minute time frame will expand, right? And so that actually limits what you can do in terms of your margin reductions. And so if you have a look here, this is a table, but we've done more work on this now. And we found that realistically, you can't really go much below 4 mil margins and still ensure that you get full coverage. And so I guess what's a bit of a shame about that is if you had, say, seed tracking on top of this, you could maybe get that down to 3 or 2. And so you could then adjust the plan for the CTV that day and then also track the PTV itself. And that would just give you much greater ability to reduce the overall impact on surrounding organs. It also reduce your integral dose on the patient as well. This is some examples of from our studies of improvements to dosimetry for patients. So you can see here we get much more for the adaptive plans, you get much more stable but also higher CTV doses. And that comes at a much, much smaller range in our rectal doses. You can see the difference here between the red, which is the standard plan doses, and the adaptive plans. And you can just see the distribution or deviation of those rectum plans are really good. And then looking here at bladder and a bladder, CTV and bowel, again, you can see just how much tighter the distributions and lower they are in general for the adaptive plans. Okay, so that's an overview of how the system works. I think we're about halfway through, but we've got to get some questions in as well. So what I'll do now is speak to the current literature, and at the very end, maybe a couple of things I think that are coming through at the moment. The first thing I think to speak to is the original kind of groups of papers were focused on implementation and validating the TPS. So as I spoke to before, there was these white papers down the bottom. Again, hopefully here I should have links. So once I share this PDF with you, there'll be links if you want to go to any of these papers and look for yourself. And the very top paper here, now this is the introductory paper from Variants. It's a great paper to look at to see what they've done. And it speaks to how they actually implemented this adaptive process. And on top of that, it also includes some interesting information about the AI convoluted neural networks they used for the auto contouring as well. So I definitely recommend looking at that paper. On the right here, we've got a couple of TPS papers. And this one down the bottom here was us validating the model against measured data that we'd measured for a couple of machines across our group as well. Speaking to that paper from Varian, so Yves is kind of the lead from Varian on this ethos development software group. And what's nice about this paper is it speaks to both the CNN architecture of the AI implementation, but also here you can say this is the Q function goal optimizer that I spoke to before. So again, it's something you can go and understand how this function works before even looking at an ethos machine. I think then, as I was saying before, we looked at then validation. So this is, as I was saying before, the modeling is not particularly good for ethos for small field dosimetry. So this is a 1x1 and a 2x2. And what you can see on the right here is the local error between our measured curves and the TPS. And you can see it gets out to kind of 1.5%, 2%, but right along the P to D curve, which is not really acceptable if you're going to use it for clinical treatment. So as a result of that, we have not used it for small field work. Now, what's interesting is another group did some characterization work across, I think, 6 or 7 ethos systems, and they actually found similar results as well. What they also noted is they actually saw some offsets even down to the 5x5 fields. But I think if you're looking around 5x5 and above, you're certainly very safe, particularly you're doing a lot of modulated work. So it's actually kind of a bigger field that's just getting broken by sublets. If we move on to the next set, which was, so once the systems are kind of validated, groups moved into phantom studies. So this one on the left here is looking at, I think, a pelvic phantom and then making synthetic data sets and then seeing how accurate it worked. And what this one kind of looked at was it kind of spoke to where the deformation broke down and therefore gave some action items on when and where you should worry about the deformation that's being used for the online adaptive process. On the right then, we've got a couple of QA papers. So one was looking at how Sun Nuclear's dose check and Varian Mobius worked with regards to ethos adaptive calculations. I think this was actually a presentation at a conference rather than a full paper. And the second one there was just a general overview about using system-based assessments of external beam radiotherapy and adaptive. And it kind of looked at all the different errors and different risks of adaptive radiotherapy. And I think it's a nice one to kind of break down the chain of like, okay, where do we have patient risks? Then we starting to move into kind of papers that looked at specific areas. So the first one is the paper I spoke to before. So it showed that the AI contouring was fantastic and that 80% of the adaptive plans were superior by clinical goals with about a 19-minute average treatment time overall. So 80% of patients were getting better plans using adaptive radiotherapy, and I think that holds true kind of in our clinical practice. I think around about 97% of fractions are treated with adaptive plans because they're always better because then matched to the patient's daily geometry. Other papers looked at emulator studies, so not real patients, but doing emulator work with kind of old patients they'd already treated, but then running through like a virtual ethos system. And they also showed that they had pretty good results with the AI contouring, but they did have some contours that they had to adjust and change. I think a little bit in the bladders, a little bit in the rectums, and some small CTV adjustments. Then moving to like prostate and seminal vesicles. Another paper looked at 12-field IMRT and how it worked against VMAT, and it showed that the ethos system currently performs better with IMRT plans. That's something that our internal researchers found as well. And then this work that was kind of presented for the Red Journal by Zhenya Ray looked to develop further margin reductions. And so they found that auto ART could achieve coverage with 4 mil margins, but this was a retro, and also down to 3 mils. But this was a retrospective study, and it didn't look at intrafraction motion. I don't think the 3 mils is actually really achievable, to be honest. And there's follow-up papers that are kind of showing that is the case. It can't be done, not with that at least seed tracking. Just to highlight one particular paper, here's a prospective study of online adaptive radiotherapy with prostate cancer patients and nodal involvement. And I think what's really interesting about this, they use 25 patients, but if you have a look at this distribution, what it's kind of showing you is when, so you can think of the left side is when the rectum V90 dose is going down, is getting worse. When you're on this right-hand side of the curve, the adaptation is improving the rectal dose. When you're in the top half, the bladder dose is getting improved, and when you get on the bottom half, the bladder dose is worse. And so what was really interesting here is you get some, so one would kind of think that you'd almost get like a distribution on the plan that would run from the top left to the bottom right, and that would be that as you improve your rectal sparing, potentially you're spilling more dose into the bladder. But in actual fact, we get the exact opposite pattern. So what that shows you is that in a lot of these cases, actually, the improvement of rectal dose actually also results in improvement of bladder dose and an improve of the CTV dose. So it's showing you that some of these plans, just the patient's internal geometry was just so different that a whole new plan was needed, and it actually resulted in a much better outcome for the patient. This is returning back to another bit of prostate work that we did. And this was looking at just of all those clinical goals we made, how often did the adaptive plan do better than the scheduled plan? And so you can see here, and how many clinical goals were better. And so you can see here some of our cases, say 11 or 10 clinical goals were better. Sometimes a lot of the time, at least 1 or 2, even 3 were better. So it's improving multiple aspects of the plan. And you can see here, there's just hardly any real cases where the scheduled plan managed to meet more clinical goals than the adaptive plan. So again, this is more evidence that it does seem to really result in better outcomes for the patient. And this is a longitudinal single patient review. And you can see here, which is nice, the dotted lines are the adapted. And so you can see here your PTV yellow for your scheduled plan, if it was used, drops around to about 80%, whereas our adapted plan is staying really nice and high. But at the same time, the scheduled plan would have resulted in a higher rectum dose than the adapted plan, which is kept down and quite solid as well. So what's nice about this is it's not we're giving up PTV coverage in turn to keep the rectal dose down. They're actually just both getting better, which means that you're actually creating a therapeutic divide, which is bigger, which means better local survival outcomes. Well, we hope better local survival outcomes, but still lower morbidity outcomes. So that really is the gold standard of adaptive if we can get there. Again, this is another review. So this is going back to Zhenya's paper that spoke to what we could actually do with margins. And again, I think, as I said, this was used an emulator. It didn't include intrafraction motion. And I think realistically 4 mils is probably the current best we can do. But with the provision that maybe if we get seed tracking, we can tighten that as well. Some more papers. So a lot of work on bladders being done by Patrick Siebold in, I think, I don't know what his center's called, sorry. But yeah, Patrick's kind of led the way on bladder cases. they implement an interesting model where they start with a scheduled plan, and then based on how different the bladder is that day, they then choose what type of adaptation they're going to do and what kind of margins they need. So it's just another way to look at adaptation. And then there's been some initial work looking at cervical and rectum studies as well. I think particularly the value comes in when you're going up into the nodal chains. If we look to that particular piece of work by Patrick around the bladder, and the bladder is a really good kind of disease type to look at because it changes so much with filling. And based on that, based on how much filling you get every day, that CTV moves. And so in a typical system, really you have to cover all those possible movements based on all the possible bladder changes. That means you have quite large PTV margins. Now with adaptive, you can really shrink those margins down because you can move your CTV daily based off your image. And this is really shown here. So if you look at the adaptive versus scheduled plan, even for the CTV coverage for the scheduled plan, you're getting down around about, what, 94%, where you get absolutely no deviation on the adaptive plan for the CTV. And I think really impressively, you can see here that the PTV for the scheduled plan, using the smaller margins, some of them come down to below 70% coverage for your PTV. And you can see the PTV in the adaptive plan is remaining like what, between 97, 98 to 100% coverage. So bladder is a really, really amazing use case for this kind of technology. The one, I guess, well, it's not really a negative, it's a good thing, but we don't see that many bladder cases, so the implementation of it isn't quite as great. And they've also did some looks at the adaptive AI contouring and showed that either none or minor adjustments were typically most of the time, maybe around about 10% or less, sometimes needed some intermediate changes. This data too is probably a little bit old. There's some changes I think they've come through varying in the AI algorithms, so they're probably even better than this at the moment. Head and neck, there's been some work done around looking at head and neck patients. I know also Raw North Shore in Sydney have done a lot of work on head and neck. There are some limitations of head and neck currently because of the synthetic CT, and we'll kind of speak to how that can be improved in the future. Lung has also been looked at, and again, there's limitations on lung because when you have large deformations with a synthetic CT, sometimes that deformation can't match that change, and that means you get incorrect density information for the underlying plan. So there's some care that needs to be done there. I think one of the really other interesting trials that's kind of come through as well is CT star. So Adam talked to some pancreatic treatments before where they have markers in. Now, pancreatic cancer is really hard to treat because not only do you have, say, that breathing motion, but you have organ change as well. You've got a stomach that changes, a duodenum that changes every day. And so therefore you have to kind of be a little bit careful with your dosing so that you don't accidentally give quite high doses to, say, a stomach or a duodenum, which are really radiosensitive structures. So what was proposed by several groups in the States was, well, let's use adaptive ethos treatments in these areas. So this is some head and neck data just showing how well the AI algorithm worked. But if I click through into, jump across into this one here. So this is a CT star data, which was SBRT pancreatic. Now this was just one initial patient, and you can see like the initial plan for the stomach D03 was what, 25 gray. But once you went to the fraction 1 plan, that dose jumped up to say 32. If you use the standard plan on the fraction 2, you've got 38 gray, and by fraction 5, we're over 40 gray. So almost double the max dose to the stomach than was intended by the plan. Now, if you then look at the adaptive plans, which are the second of these kind of column graphs for each of them, your max dose for your stomach is just staying pretty much stable. It's staying, maybe it gets up to 25.5, but it's pretty much staying at that 25 limit. So this is a really clear example of where adaptive really can make a huge difference. Same kind of patterns for your duodenums, your adaptive stay low, your small bowel as well, which is another really radiosensitive organ, staying really solid and stable for adaptive plans. And then like a little bit of a pattern for the large bowel as well. So this shows real promise. But then they took the next step of them taking a whole bunch of patients that they've held, not a whole bunch, sorry, about 7, I think, patients that they've actually treated with their standard clinical workflow, and then replanted planned those on the adaptive system, not actually treated them, but just done it as a prospective study and just to see how it performed. So what they found was that in those 7 patients, which are 5 fractions each, 34 of the 35 fractions could have been treated from adaptive and would have been improved. If you have a look at the graph on the bottom right here, this shows what all the organ doses were for the adaptive plans compared to the scheduled plans. And what you'll notice here is you see a real large amount of green at the bottom. Now, green is the adaptive plans. So what that tells you is that your adaptive plans are typically delivering much lower doses to the surrounding tissue than what the standard plans are doing. And conversely, if you look on the bottom left, this is looking at the target. And what you can see here is the target green and reds are still overlapping really nicely. So what that means is that we're managing to maintain target coverage, but reduce the organ dose. And that's really because we're recontouring those organs or getting the AI to recontour those organs, changing the plans so we avoid those organs on that day. So again, this is another case where we just can shift the therapeutic gap and really hopefully get some improvements in quite a difficult area to treat really in radiotherapy. This is another paper that we reproduced that looked at lung oligomets and cranial, just the feasibility of doing it and how to optimize it. We also provided some methods to kind of improve the speed and efficiency of these processes. So I think you probably wouldn't look at doing it in cranial cases just because you don't have the non-coplanar, but certainly an option for lung and oligo with the consideration about how well that HU density comes across from synthetic CTs. Here's again just some information on the plan qualities for some of the lung and oligo work. And I think I'd like to finalize, I think probably the last kind of paper that I want to speak to, because I think it's a really interesting use case that we hadn't, maybe wasn't intended when we first looked at adaptive ethos. But a group in Scandinavia have looked at, can we take this adaptive system that has deformation and recalculation and just get rid of the planning CT? So what they do is they look at the diagnostic CT, and the problem we usually have in radiotherapy, right, is diagnostic CT couches around. The HU stability is probably quite good, but for the patient comfort, they sit in this kind of hollowed out base and they're not flat on the bottom. And so that means they're useless for radiotherapy because they're going to sit on a flat couch top. However, because the way the adaptive or the way the ethos system works is it'll take that and just deform everything down. So as long as it's not going to deform something so it ruins the representation of the target, and we use our contours and our AI to do that anyway, we should technically be able to use that plan and just go straight to an adaptive session and use that for palliative CT. And so they went through this and they showed you could do it with thoracic and lumbar spines, which makes sense because they're central, they're not going to be impacted by deformation very much. So this is the workflow. So at the top, you've got the standard workflow where you have a planning CT, it's delineated, you do the treatment plan, that all gets checked. Everyone does a review of it. Then we get the patient on the LINAC, cone beam, and treat. And so let's say even in a very efficient department, you're looking at 5-6 hours of multiple people working. Now what they do instead is they already have a diagnostic CT that's been taken. The RO goes, oh, yep, that's what I want to contour. They put that into ethos just to make a dummy plan. The patient comes to the machine. So the patient hasn't even been in the department yet. The patient just goes to the machine for their very first session. The RO meets them there, has a consult. They get on the bed. We have a cone beam. That cone beam's then deformed and adapted. Also, their CT, their diagnostic CT is deformed and adapted to the cone beam. We already have the plan template in there, so the adaptive plan starts. The RO checks the organs and checks the target to make sure they're happy, and then we treat the palliative patient. So what they found was they could bring like this palliative single fraction workflow on these patients from what was, say, 8-9 hours even to the next day to really like a 20-30 minute slot. So I think that's a really interesting new use case. And there's kind of one other element that I want to speak to that will make that even more of an interesting use case. So these are some of the cases they did. And as you can see here, right, so on the left, you've got a diagnostic rounded out couch. And then in the middle, you've got the actual treatment image where they're on a flat couch. And then the final plan that was delivered, very, very fast treatment. These patients in pain and you've managed to avoid it. Now, where this gets even more interesting is there's the recent release of the hypersight system from Varian. So what this is the new imaging panel that has HU stability we have one of these at one of our sites, and this is an example of a dose calculation using the C/E/D for a CT on the left versus the ICVCT from hypersight on the right. And this is the dose profile for a difficult VMAT case through lung and tissue. And you can see that the dose calculations pretty much overlay. If you run a 1% 1 mil gamma analysis, you get 0 difference. So if you couple this, which is a halcyon product that can go on ethos, the one limitation of ethos is that synthetic CT. You take that out and you just calculate on the cone beam. And that starts to mean that we can start doing more lung adaptive, and we can do you can even in that case, ignore the diagnostic CT for this patient and have just a dummy CT, and just for all these palliative patients, go straight to the hypersite image and treat. And I think that's probably a really, really interesting new aspect of what can be done with these systems. So I think I've got about 10 minutes left, and I think I'm finished. So if we can probably go to questions, I guess, for the group then.
Okay, thank you, Ben, for your enlightening presentation on clinical implication of ethos adaptive radiotherapy. I have collected 5 questions from the audience. So the first one are there any difference between adaptive RT and the target RT? If they have difference, what are they?
So let me just check again. So that was, are there any differences between adaptive RT and targeted RT?
Yeah.
I don't know, I'm a bit confused in terms of what is meant in that case by targeted RT. So one instance, I wonder if the individual can just type what they mean by targeted RT for me. Do they mean targeted is in terms of focus on the PET uptakes, or?
I don't know. Okay. So let's move to another one, okay?
Yep, okay.
Okay, so the next one is how do you use synthetic CT?
Yeah, okay, so that's kind of what I was speaking to just before. So what happens is the synthetic CT is not really used, it's not shown to the user on the system. So the user looks at the cone beam CT. But what's happening in the background is that DIR is matching the original CT that you've done the plan on, which has the HU values that we know are correct for that patient, right? And it's deforming them to the geometry of the cone beam CT. And then it's used in the background for the dose calculation. And so many groups have done tests to show this is accurate within reason, and there's areas where it's not accurate. And so the areas where it can be bad is things like lung, where you've got large motion because the HU can't move across. The other area where it struggles is where you have large bowel or rectal gas come in, because the synthetic CT can't just create air from nowhere. And so therefore there you get a difference. And so that's where I think I was speaking to the fact that I think the potential of something like a hypersite system, we can calculate straight on the cone beam CT, becomes a much more interesting and much more pleasing process, I think.
Okay, so the third one is in adaptive RT, does the patient undergo daily scanning? If yes, then the CBCT or other methods, and then what happened to the overall radiation doses?
Yeah, so I think the idea around adaptive radiotherapy in general is that there are cone beam CTs every day. So in Australia, at least for pelvic patients, or actually for most patients that are using IMR VMAT, they'll have daily cone beams anyway. The exception might be breast patients at some centers, but really everything else is treated with cone beam every single day. And that's because you want to match the internal anatomy, and that's whether you're doing adaptive or not. For the ethos system, it's an iterative cone beam CT. So what that allows, because it uses iterative reconstruction, it allows for less noise and better image quality, but for a much lower dose. So the cone beams are also much lower on these halcyon systems. But it has to be used every day because that's what we're using to make the HU deformation. And it's also what we're using for the AI to contour the organs every day and the target. So we don't have that cone beam. We don't have all the information about where the organs are. We can't make the plan better because we can't see the organs. So it really is necessary. In terms of, I'm assuming you're talking about overall radiation dose tracking. So there's two things there. So the radiation dose is actually tracked in the DICOM headers of the imaging system and then recorded in our ARIA systems. But in terms of the justification of extra imaging versus and the extra imaging dose versus the adaptation, I think that's kind of where the question was getting to. And the general, I guess, position in the literature around this is that because you can reduce your margins in adaptive radiotherapy, you reduce the overall volume you have to treat, because say your 5 mil margins get dropped down to say 3 mil margins, or in some cases, some of these are 1 centimeter margins like the bladder that are getting dropped down to like 3 mil margins. And so what that does is that because it's a ring, it's kind of the orange pill effect they call it, but the actual outer ring of a structure has almost as much volume, obviously it depends on the structure, but almost as much volume as the center structure itself. And so in some of these cases, you're reducing the volume of the target you're treating by 30, 40, 50, 60%. Now, when you reduce that size, what you then do is reduce how much integral dose is being applied by the radiation as well. And so what you end up tending to find is that the reduced margins on these cases result in an overall much larger drop in integral dose for the patient than you're getting from the co-beams. So it ends up being an improvement to their overall low dose spill regardless.
So what is the total dose for the adaptive CBCT dose to the total dose?
Oh, it's
around 1%?
It'd be less. It's less than 1%. The doses for the iterative cone beam CT is extremely low. I think they're about 0.5 of a centigrade, so it would be millisievert. But I mean, obviously that dose is dispersed differently, right? You get more surface dose, but they're very low. And the say it's a typical fraction is what, say, let's say the average fraction is 2 gray. So 0.5 over 2 gray is like 0.025 of a percent or 0.25 of a percent.
Okay.
It's very, very low.
Okay, so let's move to another one. If there is no concept of ring, then how to reduce the spill dose?
Oh, thank you for that question. That's a great question. So I think I spoke to a little bit, and I probably skipped over a bit, so my apologies for that. But I spoke to how in the optimizer, there's some in the back end functions going on. And so in that you can't see. So we move the I guess little grids up and down based on priorities. But underneath that as well, there's some functions that are going as well. And so those include the system in the background puts, I think, 2 rings around the PTV and optimizes them as well and makes sure that the dose is tight and constrained as it can get. So in actual fact, the system is using rings, it's just we can't see it. And so they don't need to be added because they're working anyway. And the optimization uses them in a kind of interesting way that's probably better than us adding rings. It's in they change the value of the function based on a whole bunch of components. And so because of that, we've done tests where we added rings and they didn't add any improvement to the playing quality. You're just doubling up really on the same ring structures.
Okay, so the next one is, does weight of patients consider in this? I am not.
Yeah, no, that's a really good point. So if you get a patient who's too large and you can't cover their entire body with the image, that does become a big issue because the synthetic CT is trying to match to that CBCT. If you've cropped it, you're losing bits of tissue and therefore you're losing the attenuation of that tissue in the ray trace in your plan. So it's actually a really, really, really good point. Unfortunately, with the halcyon systems, the imaging, I think, is quite wide. I think it's a 50 centimeter bore width, but it becomes really important for things like if you're going to do, say, like breast treatments or where you're offset, that you're not cutting that patient contour. So yeah, it's a very good point.
Yeah, okay. So the final one from Joseph, is the patient-specific QA system part of ESOL as well as can you use a different system?
You can kind of use it. So Ethos is designed, so yes and no. So I guess the first thing is Ethos is designed on the adaptive radiotherapy systems to use Mobius. And that's because there's a Mobius adaptive license and it's got GPUs and it's linked to Ethos. So the whole thing about that is the 3D dose calculation check in Ethos is really fast. And that's again, right, because you want to make the time from imaging to treating as small as possible so nothing else changes in the patient after you've adapted the plan. Now, in terms of that initial reference plan that we do, you do have a lot of options. So again, you can use Mobius, but you can also export the plan to Eclipse and then send to something else. You can export it to another DICOM entity if you want. So you could send it to another TPS like RayStation or Pinnacle and do a calculation yourself if you want. It also allows you to create QA plans on Phantoms. So for the first, I think 100 patients, we always QA'd the reference plan with ArcCheck first to make sure it was fine. But then after we correlated the ArcCheck results with the Mobius results and the Mobius FX results, we stopped ArcCheck because we had no failures, or we had no discrepancies between Mobius and ArcCheck after like 100 patients at 2 different sites, so 200 patients in total. And so the risk analysis kind of flagged and there was no need to keep that.
Okay, so Joseph provided another question. How did you go about making the decision that ROs won't require for the adapted plan approval, and could other centers in Australia implement this as well?
Yeah, so this was a big piece of work. We had to speak with, I don't know, it's like in other countries, but in Australia, the general guidelines are given by the Australian national kind of entity, which is called ARPANSA, and it has a code of practice which says how you should treat patients and shielding and everything else. But then we have 7 different states, and each of those have to control the laws and the regulations. So even if you get agreement from like the Australian group in each of the states, you then need to go to all the different states and speak with their regulatory bodies to make sure they agree as well. And so that took a long time. To do that, you need to go to those groups and show that you're not making the patient's treatment any worse by doing this process. And so that was a huge amount of work where we looked at workflows about how do we make sure that the RO's wishes are being implemented by the RTs. We have a whole training program where an RT gets trained for a specific RO's contouring style. We have huge checklists that the ROs give the RTs when they're doing the checks, so they run through them. And at all times, the RO still has to be able to be contacted by phone or we use Microsoft Teams to be able to check if there's anything they're unsure about as well. So it's a huge amount of training, huge amount of documentation, lots of workflow controls, and then lots of speaking with regulatory bodies to make sure that you're covered within the law as well.
Okay.
Took us about 18 months, I think. It's a very long process.
Yeah, a huge.
But the advantage, I think, is that for at least New South Wales and Queensland sites, I think they should be able to leverage what we've done, and they'll be able to do it in the future.
Okay, thank you, Ben, for addressing the question and providing valuable insights during the Q&A section. In the end, I would like to provide you to say something to our audience.
Thank you. That's really nice. Yeah. So I think firstly, like, well done. I think it's great that you guys are attending all these kind of sessions. It's a really nice opportunity to, I guess, improve understanding and processes across like a huge wide group of physicists. I think, yeah, the interest you show in trying to improve clinical processes in your own sites is really, really excellent and should be commended. So well done to everyone on the call. And I guess the other thing is I will share these, as I said, I'm happy to share these slides with yourself, and then you can distribute them to people as you like. They'll have all the links to the different papers as well. And in that will be my email as well. And so I'm always happy to respond to people if they've got any questions they want to raise with me.
Okay, thank you, Ben. Okay, right now, as we draw this webinar to be close, I want to express my sincere gratitude to Dr. Adam Yeo and Professor Ben for their remarkable contribution to today's section. Their expertise and the passion have enriched our understanding of imaging registration and its impact on radiotherapy. I would like also to extend my appreciation to all the attendees for your active participation, thoughtful questions, and engagement throughout this webinar. Your contribution have made this section truly valuable and enlightening. Thank you once again and have a wonderful day. Now, I would like to pass the moderation role back to Professor Jim.
Yeah, thank you, Kathy.
Yeah.
I would like to take over on behalf of Dr. Jin. And at this moment, I would like to thank you so much for organizing and conducting this webinar so well. I am very thankful to Professor Ben and Adam for the very interesting and detailed talk on image registration and adaptive radiotherapy. And a very huge thank you from all the participants for agreeing to share the PPTs. It will be great, very helpful for many of us to how to study it further or to teach some students or to get the knowledge about all the links and articles and literature you shared on the slides. And it will be a practical guide also on image registration on different systems. Thank you so much. And I would like to thank the audience also for attending today's webinar. And I would like to share with you all that the next webinar, the next AFOMP monthly webinar is scheduled for 3rd August. And the topic will be Introduction of Clinical Applications of MRI Simulation. And I would like to welcome you all for the next webinar also. The link and further details will be shared soon on the AFOMP website as well as the social media accounts. The recording of this webinar also will be shared on the YouTube channel as well as the social media website and also on the AFOMP official website. And once again, thank you all for your lectures as well as moderation and all the participants for your hearty participation. Thank you. See you all in the next webinar on 3rd August.
Thank you. Thanks, everyone. Good night.